بعمات ساويرس ولا لا ولا
لا
أشوف
لا مفيش علاقة ب You can speak
you hear
Dr.
me
Iman.
Dr. Iman?
You can unmute yourself.
No, I just ask her. It's okay. Yeah, we started today by spine, and after that we have a neck and submandibular. It don't take a time.
Excellent. Can you
Okay.
unmute yourself, Dr. Iman?
Okay. Are you ready? Yeah, alaikum salam. Okay, are you okay? You attend the exam before or not?
No, it is my first time.
First
Hopefully,
time,
Zara.
okay. All right, inshallah. You are from, you attend in which country?
In Abu Dhabi.
Abu Dhabi, okay, all right. So maybe see you there. Okay, good. Are you originally from which country?
From Sudan.
You live in Sudan?
I'm currently living in Saudi Arabia, but I'm originally
okay.
from Sudan.
All right, yeah. If you are from Sudan, live in Sudan, how to examine the spine. After that, we have a session about what we call it, examine the neck and submandibular. It is important. Okay, so can you start? So suppose we have a patient examine the spine. Shall I direct you first, or we just see your impression? Okay, so suppose they have a patient, adult, usually normal, and they ask you to examine the spine. So what you are looking first?
Well, first I will ask the patient should I introduce myself and start like an exam?
Okay, yes.
Good morning, sir.
Good morning.
This is Dr. Imam Malik, one of the surgical doctors working here. May I confirm your name and age, please?
Yeah, I am Mr. Limp. I am 35 years old.
Nice to meet you, Mr. Limp. Today I've been asked to examine your back and your lower legs.
Yeah, lower back. It is examination of the spine of the lower back. Okay, go on.
And also the lower legs.
We don't ask for the lower limb, just examine the spine.
All right, okay. My examination will involve me looking, feeling, moving, and do some special tests. That is okay with you?
I don't understand what you tell looking and feel, but you can do. You just make examination. Okay? It's not necessary to explain to the patient, I looking, feel, and palpate and percuss, because this is word maybe not familiar to some patient, but it's okay. I know that you are a doctor and you examine me. You examine my back. All right? Okay?
Yes. I will start by asking the patient to stand up.
You can ask me. First, what you need to ask first?
I will ask the patient to expose the back.
Before exposure, you need to do any action or anything?
Exposure, then exposure consent first, then exposure. After that, I will wash my hand and start the examination by inspection and the gate.
No. First thing, so you ask the patient for gate or not for gate?
Yes, for gate, but gate after or before exposure, sir?
No, it is, if you make a gate, you need to expose the patient?
Well, this is the way we do it, but I don't know the right way.
Okay, no problem. It will be okay, no problem. But usually you can ask the patient to walk. It's not need to be exposed. So I make the gate. So first is the gate. What else?
After that, I will take a look for the spine from posterior and from lateral.
Okay, so first inspection, you're looking for the back and from lateral. This is okay, no deformity, any swelling, anything. After that?
After that, I will feel for temperature in the spine. And
okay, so you palpate the spine and ask the patient if tender or not. Yes.
Yes, and tenderness in the spine and paraspinous muscle and the spinous processes.
Okay, all right. After that, what you will do?
After that, there will be the movement, active movement.
How to do the movement?
Well, I will be...
You can ask me in English or in any language, can understand you. What you need for me to do?
First, I will ask the patient to bend down as far as he can.
Bent in front, you mean? Okay, yes. So bent in front. After that?
Yes. After that, to bend backward.
Okay, so you mean flexion and extension. So can you blend front, so flexion? I ask him to blend back for extension. After that?
After that, I will do lateral flexion, medially and laterally.
Lateral side, okay, and the right side and the
Lateral
left
side,
side, the
right.
rotation.
After
And
that,
after that, what you will do?
I will ask the patient to sit down and do rotational movement, moving to the
All
right and
right.
to the left.
Okay, so flexion, extension, right, left, lateral movement, and after that, rotation.
After
So
that,
this is movement. After that, what you need to do?
I would like to do the Schober test.
What's Schober test?
Schober test, it is locating from the supracrystal line.
You mean posterior, superior iliac spine?
Superior iliac spine, yes. This is the point.
Yes, and make a
5
mark.
centimeter below. Yes, 5.
And after that?
5 centimeter. 5 centimeter below and 10 centimeter above. I will measure, and after that, I
So
will
you
ask the
make 10
patient,
centimeter. You make 10 centimeter.
10 centimeter above the posterior
Above the
superior
line.
iliac spine.
Okay,
Yes.
after that, what you will do?
I will ask the patient to bend down as far as he
Okay.
is comfortable to, and measure again.
So what you expected to have?
Yes, normally it should be more than 20 centimeter. If it is less than 20 centimeters,
It is more than 20 is very much. So it may be from more than 15 centimeter or 5 centiliter. Okay, can. You mean that the 10 centimeter become 20?
Yes. No, the
Okay.
15 centimeter.
Say again?
15 became 20. The 15 centimeter became 20.
15 become 20. Okay, I agree. After that, what is significant of this Schober test? Of course, we don't need to know the name, but just to know that it is a measurement. What is the significance of that?
If the space is not increased by bending, there may be ankylosing spondylitis.
What is ankylosing spondylitis? What is this disease? What is the X-ray finding of ankylosing spondylitis?
Actually, I'm not aware of the X-ray finding.
It is called the bamboo shape appearance. Maybe next time I show to you bamboo shape appearance. So it is look by bamboo shape appearance. Okay. So which medical surgical disease in England we can find ankylosing spondylitis associated?
Inflammatory bowel disease.
Which inflammatory bowel disease? Like what?
Mostly with ulcerative colitis.
Ulcerative colitis or Crohn's disease. Okay. Is any test to diagnose this ankylosing spondylitis? Test like lab test like HLA something. Human leukocytic antigen A17 is diagnostic for ankylosing spondylitis. It is common with inflammatory bowel disease. Okay, so you make Schober test. What else you need to do?
After that, as far as I know, we need to do the lower limb examination.
So why you do lower limb examination? Looking for what?
For sciatica.
Sciatica. So what you will do? Sciatica is okay. Sciatic nerve compression. So what you will do?
I will do straight leg raise test.
Okay, you did straight test. What happened to the patient if you have sciatica?
Okay, there will be pain in the posterior compartment of the side. Yes, in a certain degree for stretching of the sciatic nerve.
Okay, so straight leg test must be done. Okay, after that, what else you need to do?
After that, femoral stretch test.
What is this?
I will ask the patient to lie down, and I will stretch his leg up.
Okay, so what it mean? What you looking for?
For femoral nerve.
Is this common? Something common in your country?
No, but where
it is routine do it in your practice, doctor?
From it is from. No, I didn't do it in my practice during my practice. I didn't do it.
If you don't do in your practice, so don't tell us because we're looking for what you practice. You mean that you make femoral? You mentioned femoral nerve stretch, and it is a common to have femoral nerve compression in practice or in life? Or
no, it is not common. The common one is the sciatic nerve.
Okay, so if it is not common and do an exam, we don't blame you. But you lost the time for the other to do it, so don't do it. What else you need to do?
Okay, as far as I know, I should do the sensation and the power for the lower limb to know if there is
power of the lower limb. Okay, like flexion, extension, something like that.
Yes, to know the myotome or dermatome affected in the sciatic nerve. To make a clue.
Just to be more specific, you need to looking for dermatome or myotome.
Both of them, sensation and power.
We can start by sensation, so you can start by dermatome, like from, so for example, the big toe is the sensation is which dermatome?
L5.
And little toe?
Little toe, it is S1.
Okay, so
On
you
the
make a
lateral side.
dermatome. After that, you're looking for myotome. You can looking for myotome or not is up to you. Okay, what else you need to do? You make a sensation. What else?
Yes. Just power and sensation. If time permit, I can do the reflexes.
You can do reflex. So what is the root value of knee reflex?
It is L3, L4.
What is for ankle?
S1.
L5, S1. Okay. What else you need to do or you finish?
I'm finished.
Okay, thank you so much. So what you do is okay. Of course, I found in the notes or the many notes, they ask about, of course, you're looking for the gait of the patient first. Gait is important. You look to inspection of the patient from back and lateral is okay. You palpate the spine if any deformity or anything is okay. You ask the patient to make full movement like flexion, extension, right, left, and rotations. All this can done. After that, you make Schubert test. The Schubert test is very important for ankylosing spondylitis. Ankylosing spondylitis is very important test because it is can be associating with Crohn's and ulcerative colitis, and it is diagnosed by lab by HLA P1717, and also you're looking for sensation and reflex. Is not necessary, is not important to do. I found it in many books, but it's not necessary to do femoral nerve stretch. It's not done routine. It is important. Something is not to do it routine. Don't do an exam because the exam is a practical examination. What you do in your life. If you do something you don't do in life, so you are not good. I found also some ask about colonus and all this. It is not important from surgical point of view, can be for neurological point of view. We don't do that. I think also myotome may be not necessary. Sensation is important because simply you ask the patient to move, so the movement is okay. You can ask also if you have a time, you can do it, but it's important to do the reflex first. Okay, so we start by gait, inspection, palpation, movement, straight leg test, Schubert test, sensation, myotome if you wish, or muscle tone if you wish, and followed by reflex. That's it. Okay, again, this is orthopedic examination. It is not neurosurgical examination. It is, we don't suppose you are expert in neurology. It is not the MRCP. In MRCP, you ask you from neurological point of view. Okay, thank you, Dr. Iman, and best wishes. You work in neurosurgery or general surgery?
I work in general surgery.
Okay, just ask in your hospital. If your hospital do femoral nerve stretch, you can do an exam. If you don't know, you don't do an exam, especially if we run the exam in your city or your country. Any question?
No, thank you, sir.
All right, thank you. Any question from other? Anyone attend this station before and have any comment? They can ask me. After that, we have a case of neck swelling. Neck swelling is very, very, very common in exam. So we ask you about neck swelling. Anyone need to ask anything? Okay.
Hello, Dr. Shireen.
Yes, hi, Dr. Nabhan.
Hi, Dr. Shireen. I was asking about the sensation. So we will
Yes.
do the light touch and then only the light touch, or we will start?
What you do in your practice?
Yeah, we do the light touch.
Okay, so you do light
Foot on
touch. Yes. So what you mean by deep touch? You mean the what you mean?
I mean by like with the pressure, you know?
You know by vibration and all this. You mean?
Yes, I mean by vibration.
Okay, of course, you don't find tuning fork in the station. Okay, so don't need to do it.
Yes, I had
All right.
this same station in Almaty exam in March.
They have tuning fork in an exam.
No.
Okay, so if you have tuning fork, so you don't need to do it. So don't do it. Don't be so clever. It is easy to lose a time, and if you don't come to the end, 100% you will fail. Okay.
Yes, that's what happened.
All right. So anyone, we can start now about neck swelling. Anyone is volunteer for neck swelling? We show you the picture of patient. Anyone?
No one goes here.
Can? Are you Dr. Iman again?
Yes.
All
If no
right.
one else
Okay.
can go here.
All right. You can start. So we have a 45 years man presented with anterior neck swelling for several years duration. So this is just to make examination. This is a picture. You can start to examine the patient. So what you start first? You see the picture or not? By the way?
Yes, I can see it. Yes.
Okay. So this is the exposure patient. Can you introduce yourself and speak to me?
Okay. Hello, sir. This is Dr. Imam Malik, one of the surgical doctor working here. May I compare your name and age, please?
Yeah, I am Mr. Limp and I am 45 years old.
Nice to meet you, Mr. Limp. Today, I would like to examine the lump in front of your neck.
Yes.
That is okay.
Yes, can.
Okay. First of all, I will start by taking a look.
Okay, by inspection, what you're looking for? What can you describe by inspection?
Yes, I can see that there is a lump on the left side, mainly of the anterior neck.
It is
There
lower part of the left side and yes?
Yes, it is. I cannot estimate the size, but it is.
No, roughly the size is, for example, 4 by 3 or 4 by 4 centimeter. What else?
Yes, skin over it is intact. There is no erythema or sinus discharge.
Yes.
Yes. Then after that, I will give the patient a sip of water and ask him to swallow, see if it is moved with the swallowing or not.
Yeah, it is moved with the swallow. It's moved up and down with the swallow. What
Okay, then
you mean?
I'll ask the patient to.
No, you need to comment. You ask me to swallow and what you see.
Yes,
it is moved with the swallowing.
So this is like to be the thyroid gland swallowing.
Okay, so if you don't tell that, if you Dr. Iman, if you don't tell me, I ask the patient to swallow and it is moved up, so it is a thyroid gland. If you don't tell this knowledge to me, shall I give you mark or not?
No.
No, okay, so it is important. I know that you know it, but if you don't see it or you don't speak to it or you don't tell us, we don't give you mark, okay? So you're asking me to swallow, the swelling is moved up and down with swallowing, so you tell me it is a thyroid swelling. Thank you. What else?
I will ask the patient to stick his tongue out and to see if the swelling is moved with protrusion of the tongue to confirm it is thyroid.
Okay, so you expected I give you mark for this test or not?
This is old patient. This is most likely not a thyroglossal cyst, and it is laterally.
Okay. So you tell me that you just waste your time and take no mark because in checklist we don't have a mark about protrusion of the tongue because this patient is not thyroglossal cyst because it is not midline. Okay,
yes.
You do it. I don't blame you in exam, but it is affect the outcome or the time limit. So don't do that if the patient have a thyroid. If the patient have no thyroid, you can do it just as a routine. After that, what you need to do?
After that, I will comment about the surrounding of the node. If there are any distended neck veins or visible pulsation, then I will move to.
Okay, go on.
For
you move to what? Palpation. Okay,
yes,
so I just you what is inspection? You're looking for the site, for the size, for the shape, for the surface, and the movement with the glutation. After that, you go to palpation. What you palpate, and from where you palpate?
From front of the patient, I will palpate for the temperature and the tenderness.
Okay, all right. What else?
There. After that, I will move to behind of the patient to palpate for yes.
Palpate for what?
For the size, to confirm the size with the tape, and to palpate for the surface and the consistency and the mobility and fixity to the skin and underlying structure.
Fixity to the skin, so you hold the skin and the underlying structure, what you mean?
I will ask the patient to flex, to turn his head to the side to put the sternocleidomastoid muscle into action.
Yes, so but the sternomastoid is not the underlying structure, it is over. Okay?
Yes.
All right.
Yeah.
So it is in front of it, not the afterlying structure, but it's correct. All right. So just hold the muscle, hold the skin, and hold the muscle. But you need to put your hand down to know the extension or not.
Yes, to know the extension of the lump from behind.
Yeah. So to exclude retrosternal extension. So by palpation, you ask the patient, is it painful or not? You're looking for size, shape, all this. Don't forget the lower border, surface, lower border again, consistency. And after that, what else you need to palpate?
Then I will palpate for the lymph nodes.
Why important to palpate the lymph node? Can you enumerate the lymph node for me, by the way?
Yes, there is a submental and submandibular,
Yes.
and peritorsular or tonsillar lymph nodes. There is anterior cervical and posterior cervical and occipital and supraclavicular.
Okay. What is the midline lymph nodes? What we called it?
The deep cervical lymph nodes.
No. Midline mean midline, peritracheal, perilaryngeal. So don't forget midline, peritracheal, perilaryngeal. Sometimes they will call it dolphin lymph node. No problem. So you palpate lymph node. What else you need to palpate?
After that, I will come from the front side to see the suprasternal notch and percuss for retrosternal extension.
You scan for retrosternal extension in which area? Suprasternal. Okay. Percussion, you mean. But you still miss something in palpation. You
Yes,
go to
I will-
thyroid. Yes,
The
go on.
carotid artery pulsation.
Carotid artery, and what else you need to palpate? Something in the midline? Okay,
trachea.
we come trachea. Okay, so after that you make a percussion. After that,
I will sculptate for aortic for carotid bruit.
all right. So in palpation, you examine the size, shape, everything, lower border, surface, consistency, trachea, carotid pulsation one by one, and the lymph node. Okay, like in this. After that, what you need to do?
After that,
Percussion and auscultation. All right. So what's your diagnosis in this patient, in this picture? This is duration. I write here is duration is many year. So what's your diagnosis?
if it is long standing, most likely to be thyroid nodule or cyst.
It is right side, left side. So it is left thyroid nodule. For further investigation, can be toxic, can be non-toxic. What is the further investigation we need to do?
I would like to start with thyroid function test, the 3T4 and TSH, and also by blood investigation in form of complete blood picture and inflammatory markers.
Inflammatory marker is important here or not?
It is important for thyroiditis.
What you mean by inflammatory marker?
Yes, ASR and C-reactive protein.
CSR and the SCR, we don't do it because it is high in acute appendicitis and everything. If you need something more specific, you can ask for thyroglobulin antibodies.
Yes.
Okay. You need to examine this patient because we don't mention it is toxic or non-toxic. How to confirm that in this patient?
Yes,
what you need to looking for?
The status by examining the patient eyes and the patient hands. The eyes, I will look for presence of exophthalmos and leg lag.
Exophthalmos, leg lag, and frontal wrinkling and the movement of the eye. What you looking in the hand?
In the hand, I will look for presence of sweating or tremor.
Fine tremor or warm sweat. Okay. All right. So if this patient have no all these signs, so it is just non-toxic. Okay. What else you need to do for this patient? For this patient, the previous patient, the first one, what else you need to do?
After clinical
you
examination,
examine him, it is non-toxic and have swelling in the left side since a few years, 4 years, 5 years. So what you need to do, you ask for T3, T4, you ask for thyroglobulin antibody. What else you need to do?
Yes, I will go for thyroid ultrasound.
Neck ultrasound. Okay. Looking for what?
Looking for the consistency of the lump and extension, and I will take biopsy.
What? No, just a minute. You take biopsy or fine needle aspirated cytology?
Fine needle aspirated cytology.
What is the difference? What is cytology?
Cytology, it is a study of the cells. structure and function. They will know background tissue structure.
Okay, so by fine needle aspirated cytology, you can diagnose all thyroid cancer except
Follicular thyroid carcinoma cannot differentiate
or
between
adenocarcinoma, follicular adenoma, or adenocarcinoma. Okay, so it is fine needle aspirated cytology, not biopsy. Okay,
Yes.
biopsy can diagnose carcinoma in situ, cytology not. So we take a biopsy for it. We send sample, we make left hemithyroidectomy. You have this picture. What is your diagnosis?
There is empty.
Okay, it is look empty, but actually the nucleus in the periphery. What's your diagnosis? It's type of cancer in thyroid. What it could be? Name.
It is follicular thyroid carcinoma.
No, not follicular. It is something you occur in young, not in this patient, but have macrocalcification called Sumoma body, empty nucleus. Say again?
Medullary thyroid carcinoma. I'm not aware of it.
No. Just a minute. It is papillary thyroid carcinoma and spread by lymphatic. So I just ask you now, what is the type of thyroid cancer you know?
There is the papillary thyroid carcinoma, follicular thyroid carcinoma, and anaplastic, and also there is the medullary thyroid carcinoma.
Okay, if the patient is 20 years old, which type of cancer is present from this? 20.
The papillary carcinoma is more
Papillary spread by
lymph node. Yes.
Lymph node. Follicular spread by blood, anaplastic, and medullary. If the medullary can be part of other syndromes.
It is called multiple endocrine neoplastic syndrome.
Okay, so is the medullary thyroid carcinoma, what is the tumor marker?
Calcitonin.
Calcitonin, yes. Okay, what is medullary thyroid multiple endocrine neoplasm? We have type 1 is all benign, like parathyroid adenoma, pancreatic adenoma, pituitary adenoma. But type 2, they have medullary thyroid carcinoma, pheochromocytoma, and parathyroid adenoma. So what is the tumor marker of pheochromocytoma?
It is chromogranin A and B.
Say again. What is this? You mean metepinephrine? You mean in the blood? But what is in urine?
In urine, it will be 5-HIAA.
No, 5-HIAA. It is the next question. It is high in the carcinoid tumor occurring appendix. But in pheochromocytoma, we have phenylmandelic acid, VMA. So pheochromocytoma, we have phenylmandelic acid. We're back to urine marker at the end. Okay. So what is the oncogene can happen in ME and multiple endocrine neoplasm type 2? What is the oncogene?
RAT, oncogene.
RAT is good. We ask you many times in exam, no one answer it. So from where you know the answer?
I study from Dr. Exam notes. Dr. Exam.
Okay. All right. So it is good. So he write it. All right. So by the way, you mentioned 5-hydroxyindole acetic acid in urine. So it means that we have 3 markers in urine. First marker is phenylmandelic acid for pheochromocytoma, which is occurring in medullary thyroid carcinoma. Second is 5-HIA or 5-hydroxyindole acetic acid occurring in carcinoid tumor in appendix. And what is the third? Something in bone. What we called it? It is Benz-Jones protein in multiple myeloma. Okay?
Okay.
All right. Good, Dr. Iman. Your performance is good. You need, when you ask the patient to swallow like this, look into the neck and the swelling move up and down. So it is a thyroid swelling. So you need to have a comment. If you don't have a comment, you don't have a mark. No need to protrude the patient tongue because you don't have a mark for it, but just lost your time. Of course, it is important at least to see the fine tremors and the eye manifestation for thyrotoxicosis to say at the end this thyroid nodule is non-toxic. Okay, your performance is okay, but don't say sir in the beginning. Sir is a rank from the queen or from the king now. So sir, if you write sir, for example, you tell the patient name in 4 times, like Sir Magdi Yaqub. Sir, like this. But if you Mr. is Mr. Okay.
Okay.
Any comment from others? Thank you, Dr. Iman. Okay. Any comment from others?
I did
Anyone
enjoy
have
I
the
did
same?
enjoy all your information, Professor Shireen Hariri.
Thank you, thank you. We have the
Excellent.
submandibular after that, so we can speak about submandibular. We just still have a time. So anyone volunteer again for the submandibular swelling? It is very, very, very common station, and I leave you, and we can see what is your impression. Anyone have submandibular before in exam? It is fixed, but sometimes in some country we don't find the patients who bring a normal one. Anyone can volunteer again. We have another Iman.
Yes,
Are
I
you?
can.
Yes.
I can
Okay, Dr.
volunteer, doctor.
Nabhan. Okay, you can see. So this is the patient have a swelling in submandibular region. Can you start?
Yes.
Mhm.
Hello, my name is Dr. Mohammed Abhan. I'm one of the surgical doctors.
Okay.
May I confirm your name?
Yeah, I am Mr. Limba, and I am 45 years old.
Okay, Mr. Lim. Can I call you Mr. Lim?
Yeah, can.
Okay, Mr. Lim. So today I have asked you to examine your the lump in your leg. Are you okay with that?
Yes, okay, can.
Yeah. Firstly, I will start with the inspection of the swelling.
Yes.
I will start to see the site, the size of the swelling, the shape.
Okay, can tell me what is the site? It is in the right side of.
I can't see anything in the
You
screen.
don't see it. All right. So I need to share again. I suppose I share. Okay, okay. Okay, entire screen. So you see it now or not?
Yes, I can see it now.
Okay. So this patient have a big swelling, and we usually in the station we ask you examine the submandibular region, not examine the neck, by the way. Okay, so you can comment.
So this is a swelling in the anterior part of the right side of the neck. It's
Okay.
about 20 and 20 millimeters.
Okay.
There is no scars. There is a little bit of dilated vein over it
Okay.
on the upper side, and the overlying skin is looking normal.
Okay. So this is by inspection. What else you need to do?
Yeah, we'll start with opening the patient mouth to see his oral cavity and Barton's duct.
Okay, we open the what you need is we open the mouse. What you're looking for?
I will look firstly for the Wharton's duct to see if there is erythema, if there is any signs of infection.
Okay, so you tell me you're looking for Wharton duct. I don't give you mark for that. Why?
I
Because you
don't know.
don't tell me what is the exact site. I looking for Wharton duct in where?
Just beneath the tongue. I will
Okay,
ask
so ask the patient to elevate this tongue like this, for example, and they're
Yes.
looking for Wharton duct or submandibular cerebral gland duct. So if you don't tell me where you are looking for or what is the site, we don't give you mark because the mark is for mention the site. Of course, you don't see the duct, but you just tell me it is here. What else you need to do?
I will start with the palpation.
You need to palpate from inside or outside first.
I generally might do from outside first, then I will go
Okay, so
inside.
it is better to do from outside looking for, it is not tender for me, okay, and is not hot, and as you see, it is a smooth surface. After that, you go to inside. What you need to do from side?
Yeah, I will
Inspection,
do a bimanual examination
what is the value of this bimanual palpation of the gland?
to see the deep ducts of the gland, if it's enlarged or not.
This is not the correct answer. What is the correct answer? The correct answer, if you feel it from down or you feel it from up.
Okay.
You need to answer me. If you feel it
I
from
did.
up, what it could be. If you feel it from down, what it could be. Like this. Suppose this is one, like this picture. Yeah, this is the left hand from down. If you feel it from down, what it could be. If you feel it from above, what it could be.
From down, it will be the superficial part of the gland, which is enlarged.
No,
Which the
we
deep
don't speak about this patient. We speak in general. If you palpate it from down, it is and rolled over it. It could be usually.
the superficial
You don't.
part.
No, the superficial part you don't feel it from down. What you feel down is a lymph node. We speak about
Okay.
normal patient because in exam we usually have a normal. What you feel inside is a gland. You can feel to differentiate between submandibular salivary gland and submandibular lymph node. You do bimanual examination. In this bimanual examination, if you found the swelling from the mouth, so it is submandibular salivary gland. If you palpate the swelling and roll in your hand from outside, so it is submandibular lymph nodes.
Okay, I
Okay.
understand.
What else you need to do to examine?
Okay, I will see if the edge, from outside. I will see the edge and the
No, still
consistency.
from inside. Still from
From
inside. What
inside?
you looking for? Yes.
I think I will just see it and the Wharton's duct.
No, not only the Wharton duct. You're looking for any dental caries because this patient, as you see here, most probably
Yes.
the patient had dental caries, and this dental caries can precipitate a stone or infection in submandibular salivary gland. After that,
Okay.
what you need to do?
After the dental caries, I will
Yes, yes.
continue my outside palpation, then I will go for the lymph nodes.
Okay, so you examine the lymph node from back, okay, neck lymph node as this. After that, of course, submental, submandibular, preauricular, postauricular. You need to tell me the names of it during examination. Upper, lower, deep cervical. Okay. What else you need to do?
I think nothing.
Nothing. Okay, good. All right. So what I see in exam, of course, inspection, palpation, bimanual palpation. Don't forget to examine the neck lymph node. If you forget to examine the neck lymph node, so usually the examiner asks you what else you need to examine. So you can examine the lymph node. Just when you examine, you need to enumerate submental, submandibular, preauricular, postauricular, occipital, upper, lower, deep cervical, and sometimes prelaryngeal, pretracheal. Okay.
Okay.
Neck lymph node examination. What I see in exam, and I don't need to do it, it is some student. Okay, we can ask the others. Anyone need to add anything? Anyone need to add anything in examination? Okay, so what I
Examination?
see, yes, say again, yes?
Nerve examination.
Nerve examination, it is good. It is done by a student, but you expected this have a mark or not a mark, Dr. Iman? Which
Suppose
nerve
not
you need to examine? Just tell me which nerve you need to examine.
the hypoglossal nerve. and
Okay,
the multi-
hypoglossal nerve. Okay, so hypoglossal nerve, it is damaged. It is due to what?
commonly due to carotid surgery.
No. We speak about this case. It's due to surgery
case,
or before surgery?
No, due to surgery.
Due to surgery. Okay, so no need. I found
And
all
the
the
lingual
student
nerve?
in exam. I attended this station many times. I found the student ask, like Dr. Iman say, tongue for sensation, lingual nerve, anterior third of the tongue, movement of the tongue for hypoglossal, angle of the mouth for marginal mandibular branch of facial. Actually, all this is not necessary. Why it is not necessary? Because can happen after surgery, not before surgery. So you can, during surgery, you can injured the marginal mandibular in the incision. You can injure it in the deep dissection lingual and the hypoglossal nerve. You can see the relation. It is more deep like these slides. Okay. So back, usually after you finish, we can ask the same doctor, what's your diagnosis?
My main differential diagnosis will be inflammation of the submandibular gland.
Okay, so what is the investigation you will do?
I will start with the full blood count.
Okay, after that?
I
More
will
specific
ask
investigation.
for I will ask for ultrasound of the submandibular gland.
Okay, can be ultrasound looking for the gland and the lymph node. Okay, so we did ultrasound. We have two options. One patient have submandibular salivary gland stone. The second have a stone in the duct, in the gland itself. So how to manage both one by one? Stone in the duct. How to manage?
I think conservative treatment is always a start with
No.
anesthesia and
We need
oral
to remove
antibiotic.
it. How to remove it? Of course, we improve the oral hygiene and give antibiotic and hydrations, but how to remove a stone in the submandibular salivary gland? Anyone can add? We have a stone now in submandibular salivary gland. What you will do?
Cyalography.
Say again?
Cyalography.
Cyalography. So if you tell me, so in your hospital, again, Dr. Iman, you have cyalogram done.
Actually, I'm not aware of it. I'm not working with.
Okay, it is done routine. It is available in your hospital or not?
I'm not sure actually, doctor.
Okay, so if you are not see it in your life and at least you work more than 1 year in the medicine in surgery, so we don't do that. Cyalogram is a historical. So what else you can do? Anyone? Yes. Say again. What you say? Say again.
The excision of the gland.
Not excision in the duct. Just open the duct by local anesthesia, usually done by dentist, and to remove the stone like this. So it is called marsupialization, or open the duct and don't close the duct. Leave it open. If it is the stone in the gland, remove the whole gland.
Okay.
What happened in exam? In exam, I found some students say cyalogram not done, X-ray can done, ultrasound done. Endoscopy is not done at all. We don't see in my life. So the treatment is just conservative, improve the oral hygiene, clean the teeth, correct any problem in the teeth. After that, if the stone in the duct, open the duct by local anesthesia done by dentist and leave the duct open, remove the stone. If the stone in the gland itself, remove the gland. So again, no need to examine the lingual, hypoglossal, and margin mandibular. So back again. First, Dr. Nabhan. First, when you start, you say me hello. Don't say hello to the patient. Just say good morning or good afternoon. Okay, this is first. Second, usually we know your background. Like, for example, we go to Abu Dhabi, Dr. Iman working in Abu Dhabi in big hospital there. So, of course, cyalogram or cyalography is never done. It is like barium enema or barium something is now historical, because now we have ultrasound. I found the majority of the students say cyalogram. So we don't diagnose the stone in cyalogram because usually it's diagnosed by dentists. He have something called panoramic X-ray or neck ultrasound. Of course, if the patient post-operative, we need to examine the hypoglossal by movement of the tongue. We're looking for the angle of the mouth, and we're looking for sensation in the front of the tongue. Of course, this is don't need to put something to be tested by the patient, just ask him, and this is done post-operative. So if you have a patient in exam, which is not common, post-operative, you can do that. Okay. What I see, as you see, the exam is easy, clinical is easy, everything is easy. But what problem of the many student is just you ask for something non-necessary, like, for example, protrude your tongue to examine the thyroglossal cyst, which is not the issue today. You can do some test is not done routine. So if you found some, even in book of I tell something is not done in your hospital, we don't need an exam. So it is lost of time. Usually we leave you. Last time I was in submandibular salivary gland, all the students examine hypoglossal, lingual, and marginal mandibular, and forget to examine the lymph node. So of course they have bad mark because they don't examine the lymph node. So if you don't examine the lymph node, it is not good. The same for thyroid. You can perform it very good, but you forget to examine trachea, you forget to examine carotid artery, you forget to examine lymph node, you forget to examine attach it to the skin and overlying, not underlying muscle, which is a sternocleidomastoid muscle. So you can have 4 mark or maybe 6 mark lost, and you did very, very, very excellent examination of the thyroid gland. But at the end, your mark is not good. So the exam is tricky, and depend on you need to do in short time, in 9 minutes, 10 minutes, everything. So something unnecessary, not routine, don't do it, because we leave it to do it, because if I ask you why you do that, we lost another 1 minute. If you protrude your tongue, patient, and ask why you do that, so you tell me, are you looking for thyroglossal cyst? So I tell you, is this age of thyroglossal cyst? No. So we lost about half minute, 1 minute, so it is not good. Of course, when you pass the exam is easy, failing exam is easy also. Okay, and the aim of exam, the OSCE station, is just to collect a mark. All right. Any comment from other? Anyone have a query or something to need to add?
Regarding examining inside the mouse, sometimes they prevent the candidate from putting the finger inside the mouse, although he has gloves and everything like that. I usually in my station, if you tell me I will try to feel it by manual, I said, okay, fine, no need to put your finger inside. Will that be okay?
All right. Yes. And last time in India, we allow the student to examine. So no, but it is according to the patient willing, and different from center to center. In India, the patient accepted. I don't know about Egypt and other country.
Yeah.
In Malaysia, they are accepted. Maybe in Abu Dhabi, what is the nationality? Depend on the nationality of the patient.
Yeah.
But of course, don't forget, because Dr. Nabhan, when asked, he don't forget to examine teeth. Of course, you have a light source you can find on table.
Yeah.
So you need to examine the teeth for dental caries. So it is important also to know anything in the side table you need to use. So in thyroid, you can find the paper for fine tremor, you can find water for ask the patient to drink and swallow. So all these are very important. It is important because I found many students have a belief they don't speak during examination. When we say we don't speak during examination, mean don't speak with the patient, but you can speak. Like I examine, I found the swelling move up and down, so it is a thyroid swelling.
Yes.
So how know that it is a thyroid swelling if you don't tell me? So you need to tell me the result. Suppose you palpate the swelling, it is hard swelling, so it is hard inconsistency. Because you don't present at the end, so what you found positive, or what you do it, you again, as I mentioned, you put your hand here. So I don't know, you examine the carotid, you examine the lymph node, so you need to enumerate the lymph node, name of the lymph node, or I palpate the carotid, or I palpate whatever I palpate.
Yeah.
Any student question? Anything? Dr. Iman Amer, you entered the exam before? Or Hakim, you entered the exam before? Anyone entered the exam before? No one? Okay. Dr. Nabhan, you have the same station of thyroid or submandibular?
I had spine examination.
Yes.
And the cerebellum examination.
Yes.
And I had...
you must have... yes, because the spine, cerebellum is considered as... not considered... cranial nerve can consider as head and neck, maybe cerebellum as a head and neck. But usually we have either thyroid, we have cerebellum, we have cranial nerve, we have submandibular, all these considered, because you must have one station head and neck, one station vascular, one station orthopedic, and one station examine the abdomen. So I think your neck...
I had abdomen, yes.
Okay, so it is important to know that we have one case abdomen, one case neck, head and neck, including submandibular, thyroid, cranial nerve, which is common, cerebellum, which is less common, and spine, hip and knee, and the spine is also the common. And again, like something like femoral neck stretch, you did an exam, Nabhan, or not?
Yes, I did it, yes.
Femoral nerve.
Yeah, honestly, what happened with me that I wasted some time of...
but what is the response of examiner? What is the response of examiner? He asked, he don't interrupt you.
Yeah, he didn't interrupt me. He seems like he don't care what I'm doing.
No, because you know that I usually I am in the kind team, so I usually ask the patient don't to do that. I found the student at the end they complain from me. He stopped us to do this test, and we believe that it is important. So I stop to complain to comment because sometimes I found the student do some non-necessary. So I tell stop that, don't do that, go the next step. So he complain at the end. He don't allow me to do
Yes.
this test, for example.
I was just
And
to
of
tell
course, it is
Nabhan,
not necessary.
yes, that we
Yeah.
as an examiner, if you want to do tests that is not needed, we should not instruct you to tell you not to do it. Professor Shireen
Okay.
is the kind examiner. But if you
I see
start
here.
to harm the patient, then we stop you. Like, for example, gagging reflex, or putting your finger inside the mouth, or anything that might injure the patient, then we stop you, don't do this. But other than that, we leave you, which is really quite fair, because I want to see in 6 minutes how you spend your time forward in getting the information. So if you done something that is not needed, which happen a lot, examiner should not stop you. Because this is
Okay.
called prompting, which means I am redirecting you to the correct way. No, if you done something wrong, there is no prompting. And this is also another advice, because we instructed to get facial expression, not to say yes or okay or this is good, but to have a mask face. And a lot of Egyptian doctors think that mask face means that he has done badly. And this you must get used to it. Professor Shireen is a kind examiner, so he give you a bit of a smile if you are progressing forward. But the British examiner, completely mask face. If you are 100%
Yes.
perfect, you will not get facial expression. So you better get used to this mask face during your answer.
Yeah.
Yeah.
Okay.
Okay.
Just to know that the who fail in exam is not mean that they are bad student, but he's have bad management of time. So
Yes.
99% who fail the exam is not for the knowledge, is had bad management of time. And if you ask to complain for the result in the college, he say in this station you have 20 question, you answer 12, you answer 15, you answer 10. So you waste the time for unnecessary procedure, and we have many topics down, you don't do it. Okay, so this is the cause of failure. It is very common, and very common in Middle East. The main cause of failure is just don't bad management of time, which is very common.
Yes,
Okay.
understood.
Absolutely
All
right.
right.
Yeah.
Okay.
Okay. Thank you very
We
much,
still
Professor
have
Shireen.
few
Yeah.
minutes, I think.
No.
All right.
Yeah.
Still have a time, or we finish?
No, I think we finished. It was a brilliant
Okay.
virtual station. What do you plan for us
What
next?
you need for next time? Any suggestion for the candidate for next
If the
time?
candidate wants a specific station,
Can we cover some of the knowledge stations so we can know what's new in the
Okay,
knowledge?
we start in pathology or physio. Okay, we come in pathology and some anatomy. Okay,
Critical brief, doctor.
say again.
At least critical care, at least one station.
For
Because
what?
there is
Acute
critical care
surgical
of
science and critical care.
Critical. Okay, critical care. Okay, so we can have one station in each. Okay, no problem. So next time, what time, Dr. Muhammad? It is Wednesday.
yes, Wednesday, same
Yes,
time,
okay.
5 p.m., same link with these two beautiful stations, inshallah.
Okay. All right. It will be 10 in Malaysia for Malaysian team, by the way.
Yeah,
Okay. Thank
Malaysian
you.
team, 10 p.m. Thank you very much.
Okay. Thank you much.